Um,
How's the lighting though? Let me see here. Hold on, because I feel like I'm in the shade. Let me see if I do this. That's no good.
no, the other way is better. You look like you have a glow, like a god.
That's. I'm just trying to put some lights on here. It's not.
I just
Let's see.
put a virtual background on for me, just so that it's neutral.
You want me to put a virtual background on?
No, no, you're fine.
Oh, okay.
All right.
All
So,
right.
so this is the purpose of the meeting. Okay. So, the idea behind here is that doctors constantly have this perception in the community that we're always busy to do anything. We're always busy, 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 and I don't know what it is that we do that keeps us so busy, that is productive and that really is valuable and that's economical and that's really produces true societal values versus busy work. So the second thing is, while we talk to each other at times, like you and I do, we don't talk to patients enough to educate them. And so I think we need to do more of that because that's the change in the societal expectations these days. And the third thing is, the medium by which we are educating patients is now a lot more simpler and easier because of tools like this, whether it's Instagram, whether it's Facebook, whether it is Zoom meetings these days or a combination of them. I think it gives patients a lot more access to information and because of the proliferation of these types of events all over the place, I kind of find it difficult to kind of decipher a lot of the biases that patients develop because of what they read or hear about it that may or may not be true or valid or authenticated by experts in the industry, so to speak. And so one of my things that I'm trying to do during this downtime is to try to talk to surgeons and physicians that I personally work with in different areas of specialties like breast surgery, face surgery, skin cancer, things of that nature, and try to put out some content out there so that we also have a voice that is very real and authentic and actually valid, and medically, relevant versus sensationalized information that's out there, this day and age. So that's the purpose of this meeting.
Okay.
All right. So today,
I'm just playing around with my monitor here to get the best picture. So before we get going here, let me just.
I was recording that, Fred.
Huh? Just a little technical corrections. All right.
I was recording that. But anyway, so we're going to officially start now. Okay. We're going to try to keep it simple, 20, 25 minutes max. This is just, people's attention span is, only so long. So anyway, so first and foremost, Dr. Herman, it's a pleasure to meet you. You and I have known each other for almost about 9 or 10 years now since I've moved to Florida, and we worked a lot together as colleagues and surgeons, and also as friends got to know each other. So welcome to this very short segment about breast surgery and collaboration with breast surgeons like yourself and plastic surgeons like myself, so we can disseminate good information to the audience, specifically the customers or the patients out there. So welcome.
Thank you for inviting me.
So please tell us, your background and your surgical experience in breast surgery specifically.
So I'm a board certified general surgeon, and I specialize in breast surgery diagnosis and treatment from the surgical point of view. I've been doing this for over 30 years in the West Broward and Plantation area.
Great. So tell us, Dr. Herman, what are the types of changes, in a broad scale you've noticed in breast cancer diagnosis for patients these days as compared to maybe 10, 15 years ago?
So the first change I'd like to talk about, and I think probably the biggest event, so to speak, or change over the course of years, is that breast cancer has become a multidisciplinary disease and treated in a multidisciplinary fashion. And what that means is many years ago, breast cancer was seen as a surgical problem, and all pretty much diagnosis and treatment was done by surgeons. There was obviously medical oncology was involved and so on, but it was kind of disjointed the way things were run. Today we try to get all the parties involved, and the outcomes have improved dramatically. So the multidisciplinary involves the surgeon and or surgical oncologist. It involves the medical oncologist. It involves the radiation oncologist. It involves the plastic surgeon. So in the diagnosis, we try to figure out exactly what's going on. And we do this by meeting of all the different specialties that I just outlined. And then we proceed with diagnosis through treatment and follow-up treatment. And the treatment is varied specifically for the type of and nature of the particular breast cancer, because the other development over the years has been that breast cancer turns out to have a lot of nuances about it. And it gives us a fairly good options to do different things tailored to the individual patient.
Great. So in follow up to that, and specifically in regards to patients that plastic surgeons see specifically, so would you recommend that a young woman in her 30s, 40s, 50s, or whatever, that age range in general, get any type of diagnostic testing done prior to undergoing elective cosmetic breast surgery, in your opinion?
In general, the answer is yes. So first, let's say that we try to follow the American Cancer Society guidelines for doing diagnostic tests in women. And what that means is that we recommend that all women get a mammogram at the age of 35 as a baseline. And then they don't have to get another mammogram until they're 40. And then usually starting at 40, all women would get a mammogram every year after that. If there's a family history, then we move it up either 5 or 10 years, and we may get the baseline at age 30 and then begin mammograms at 35. If we have women undergoing elective cosmetic breast surgery, then we may want to get diagnostic testing, mammogram and or ultrasound prior to that test as well, based on the patient's age and family history.
That's very helpful information for patients, so, in these asymptomatic negative family history patient base, patient population that comes for elective breast surgery, is there a specific diagnostic test that is better than others, or would you recommend all radiological diagnostic tests? So, for example, a lot of patients get confused, and I hear this pretty much all the time. I mean, do I need, if I'm going to get a diagnostic test, should I get a ultrasound first and that's enough? Should I get an ultrasound and a mammogram? Should I get an ultrasound, mammogram, and an MRI? Or could I just get past getting an MRI because I'm an asymptomatic, young, with a negative family history, just as a routine, baseline examination?
So the first thing is we have to define what is young. So if we're talking about a 20 or 25-year-old,
as young.
like us, young like us is different than young like others.
Right.
So once again, if we're talking about a 20 or 25-year-old, and maybe even up to the age of 30, one could make the case that no testing is necessary at all. Once we get to the age of 30, as I alluded to above, then we have to take into account family history. The other thing is I think we have to take into account the nature of the surgery. I think there's a misconception out there that if you have breast augmentation surgery, that it becomes difficult or that you can't have accurate testing done, such as mammograms. And that's just not true. I think the diagnostic capabilities and the level of technology today, that mammograms are available with high quality results for women who've had what I'm gonna deem simple breast augmentation, meaning implant surgery. Women who have breast reconstruction and implants, with or without implants, that's a different thing, which we can discuss in a few minutes if you like, because that involves a lot more surgery. So to answer your question a little bit more specifically, keep in mind that we have 3 diagnostic tests that are very useful for breast imaging and diagnosis, and that is breast mammogram, which utilizes x-rays. We have breast ultrasound, which is a totally different test and utilizes breast sound waves. And then we have MRI, breast MRI, which uses a whole new technology using magnets and protons, etc. The gold standard today has been and continues to be today mammography, which is X-ray of the breast. Now, this is the oldest technology available, but it's not old technology. So the mammogram done today is not the same mammogram that was done even 5 years ago, but certainly not the same mammogram that was done 20 years ago. And the analogy is we take pictures today, and the pictures on your camera or on a camera that you can hold in your hand is not the same as a camera or even a phone that you had 5 years ago, or certainly 10 or 20 years ago. So the technology for mammography is much improved, and we consider mammograms the gold standard. In fact, of those 3 tests, if you can only get one test, the test that you should get is a mammogram. Ultrasound is a very good test as well. MRI is also an excellent test. And because it's the most technological, it's the one that people are hoping would be the best, but it turns out it's not. So it's also the most expensive. So mammogram and ultrasound are the best tests. MRI for diagnosis and for screening. MRI we reserve for special needs.
So what is your view? This is another very common, kind of question that I get as a plastic surgeon all the time, and so if you take an asymptomatic person and you try to do screening examinations like this at a young age, and you do identify these noises, I call them, that may or may not be relevant, and that creates a situation where now you kind of have to, flag it and kind of follow it and kind of, create maybe unnecessary worry or unnecessary comfort. I'm not exactly sure, but that happens, maybe more frequently than we think, and that now may create an obligation to intervene in some fashion. So, is there any comfort you can provide patients that a good radiologist or a good breast surgeon like yourself is able to put things at ease if there's noise in the X-ray that may point to a lesion or something that pops up?
So that would be once again, that would be the reason to make sure that we're getting the diagnostic tests appropriate. In a patient that's 20 or 25 years old with no family history, I don't think it's necessary, and is going to have simple implant surgery. I don't think it's necessary to get a mammogram or ultrasound. And when I say asymptomatic, that means that the patient has to be examined and evaluated. If there's a reason to get a test, for example, a young lady, 25 years old, has a lump, palpable lump, a thickening or something like that, then we have to do some diagnostic testing. And usually in a young woman, we would start with something like an ultrasound, which should be fairly accurate in helping us to decide whether we need to do more diagnostic testing. But keep in mind, ultimately, if there is what you describe as noise, meaning something there that we need to know what it is, then the simple answer always is, let's do a biopsy and know. Especially because today we do almost all of our biopsies with a needle. And so it's truly minimally invasive and disruptive procedure and can give us, very accurate information. But once again, that would be unusual in most young, and depending how we define, but most young women.
Okay. And then, as a follow-up to that, let's just assume that a patient does have breast surgery, elective breast surgery. And how soon after that would you recommend people go back to getting, diagnostic X-rays on a routine basis based on, of course, age criteria? So what is a safe time period? Could you wait a year, in your opinion? Is it like, could you wait 2 years in some cases? What is your opinion?
So once again, it depends on the age of the patient and the nature of the plastic surgery, that reconstructive surgery that they had. In a 20 or 25-year-old woman who had simple implant surgery, I'm not sure that we would be getting any diagnostic testing before. And if we didn't, and if we chose to for whatever reason and it were negative, I'm not sure that we need to get any diagnostic testing afterward until the appropriate time, be it 30 or 35 years old, following the American Cancer society guidelines. On the other hand, if you're doing breast surgery on a 30-year-old, 35-year-old, certainly a 40-year-old, then we need to follow up with routine surveillance. And the time, if we had a woman who was 40 years old, decided to have reconstructive breast surgery, and prior to her surgery at 40 years old, she had a proper workup, which in a 40-year-old, I would recommend that they have a mammogram and an ultrasound, not an MRI, prior to surgery. And if the mammogram and ultrasound prior to surgery were negative, and then the patient went through with their surgery, I think they would just follow the normal guidelines after that. And so they wouldn't have to wait any particular time other than for their annual screening, which would be 1 year, approximately 1 year later.
So how prevalent do you think it is this day and age that, patients, of all types are getting routine surveillance for breast pathology? Is it pretty routine now? Do you think, there's still a lack of adherence to those guidelines because of insurance, approvals or whatever? How do you think it's this day and age? How prevalent is it?
Well, what age are we talking about now? Because like I say, it's age and family history dependent. Sorry, I missed it.
35 and above.
How prevalent are women getting? Your question is how prevalent are normal women getting these tests?
Yeah, that's correct.
I don't know the data for the United States. My guess is it's very high, but unfortunately, we all see the numerator and we don't know the denominator.
Understood.
Meaning that, everybody I see comes to me because they've had the test. And I assume compliance is very high. Most women I talk to know to go for their yearly mammogram. But I don't know what segment of the population is out there that doesn't do this, either for personal reasons or for financial reasons.
So another question that is very common that I'd like to clarify for the audience is this. Let's just assume that a patient has had surgery and has an implant of some type, whether it's a saline implant or a silicone implant, has an implant, and we do on surveillance find a little mass or a lump or some finding that needs further investigation. How confident, or what is the, let's just say maybe what is the likelihood of causing any implant damage during a routine biopsy if that does need to happen? Is it something that nowadays is very, very sophisticated technology with imaging that the likelihood of damaging something is very low, or how do you advise patients?
So in general, I think the risk of injury to implant during biopsy is extremely small. In other words, 99+% of the patients have nothing to worry about in terms of the implant being injured during the biopsy. Keep in mind that most of the biopsies we do are done with a needle, and they're done under image guidance, meaning they're done under X-ray or ultrasound guidance. So we know where the implant is all the time, and we know where the needle is all the time, and we can avoid the implant. So it's actually very, very safe. And I say it's 99% plus for that reason, because we're actually watching what we're doing and we know where everything is. Nothing in medicine is 100%, unfortunately, and there's always the possibility that something else could skew those results, and that's why I have to say it's 99%. But I feel very comfortable and safe that doing needle biopsies under image guidance in women poses very little risk to their implant.
A very, very common patient question again. Do you have any evidence that you've seen or heard about over the last 30 plus years of your experience in breast surgery, that implants themselves can cause any issues of growths or problems in the breast itself? Have you seen anything like that, or have you heard anything like that?
Well, we hear about that, but that is all anecdotal information. There are several large studies that have documented that there is no danger from implants causing cancer. So implants are felt to be extremely safe and should not increase the risk of breast cancer.
Well, having said that, we have now documented in the plastic surgical world a very rare type of cancer called ALCL that is been very much associated with breast implants, and the number of patients who have this type of breast cancer called ALCL is quite low, just only in the hundreds of the millions and millions of people around the world. That's something that we have recently documented, and we routinely educate patients about that. But I have not seen or heard any other type of true breast cancer that originates from any type of breast surgery that has been done.
Well, I agree with what you're saying, but you're citing once again a numerator which is in the hundreds and a denominator which is in the multi-millions, meaning that the risk of this is a fraction of a fraction of a fraction of 1%. So significantly small. Number two, you're talking about a very rare form of cancer, not true breast cancer. So, and which may or may not be a reaction from the material used. But once again, there's no evidence to show that any implants cause the typical type of breast cancer that we're used to dealing with. The standard common variety breast cancer that we deal with.
Great. So how have you seen the collaboration between a breast surgeon like you and a plastic surgeon like myself evolve over the last 5, 7, 10 years? Do you think that many patients know this day and age that there's this very elegant collaboration that is possible and doable, where we can get amazing results even in difficult circumstances? Or do you think that the patients need a lot more ongoing education and understanding of possibilities in breast surgery in general?
I'm a big proponent of education, so education is always good. The more we know, the better we are. We work with, myself and my surgical group work with plastic surgeons and like working with plastic surgeons. I always tell patients that after the diagnosis is made, I have two goals in mind. Number one, I want to give them their best chance for cure. Number two, I would like to leave them with a breast that is attractive, a breast that is normal appearing, and a breast that is not just cosmetically, but emotionally and psychologically acceptable to the patient. And so those are my two goals. Now, goal number one, I want to give them their best chance for cure. The good news is that today, as you asked me earlier about the changes over the years, is that we've gone to lesser and lesser surgery, meaning that we do a lot of lumpectomies as opposed to mastectomies. And therefore, this is...
There is basically lumpectomy essentially means you take out a little small piece of the area versus taking the whole breast out, right? That's the difference.
So, right, lumpectomy is removing a part of the breast as opposed to a mastectomy, which is removal of the complete breast. And there was a time greater than 30 or 40 years ago when that was considered to be the only treatment. And no matter how small the cancer, no matter where the cancer was in the breast, all women were having complete removal of their breast, that is mastectomy, at that time. Years later, and especially today, we know that that type of treatment is not necessary for most cancers, especially small cancers. And let me add that today, most cancers we find are small because women are, going back to your question, most women are aware and most women are getting their standard surveillance testing on a yearly basis at the proper time. And so when we're detecting something quite small, and therefore the treatment can be tailored to that. And most women are having just removal of a small portion of their breast with preservation of most of their breast, which cosmetically in itself is a good thing. Additionally, even if we're doing lumpectomy or removal of just part of the breast, we may, as the surgeon, use plastic surgery techniques or bring a plastic surgeon in to help us, so that even by removing a small portion, we want to leave the patient with the best looking breast that we can. Keep in mind, my number one goal is we don't want to compromise the patient's long-term cure. So whatever we do, that is the purpose. Now, some women, for either personal reasons or sometimes because of the nature of the cancer, need to have a mastectomy today. And then, of course, we work completely in conjunction with the plastic surgeon. And if we were to do a mastectomy, we would make sure that the patient, after seeing us and having proper workup, proper diagnosis, etc., then plan and schedule surgery in conjunction with plastic surgeons such as yourself, so that in the operating room we have both the breast surgeon and the plastic surgeon to make sure that after we do the mastectomy, that the patient has the proper type of reconstruction following or concurrently with the surgery we're doing.
Well, Dr. Herman, it's always been a pleasure to talk to you, to work with you, and look forward to continuing for a long time. So don't retire anytime soon. And this is the first of I'm hoping to be a series of these things that we could do, on a direct physician to patient level, I think, which is the best way to educate patients versus big meetings and conferences and get good information out there. So I look forward to maybe doing another one more specifically with have patients join us and ask live questions in the near future.
Well, thank you for inviting me. I've enjoyed this, and most importantly, I hope we've been able to reach out to people and provide them with good information, help them make good decisions and good choices, and keep them healthy. For our next meeting, I hope that I work on my lighting, because we're all working from home now because of the pandemic, and I feel like I've been in the shade here. And perhaps I'll move to the beach, and then I can sit on the sand next to you for your, yeah, I know. Just making fun that you have the artificial background there, right?
Background really is amazing because I'm sitting by the beach right now, correct?
Exactly. Anyway, thanks for inviting me.
Bye-bye.
Bye.